a 9-month-old infant with a progressive increase in head circumference posted for VP sham, sir. So first, I'll ask about history of presenting complaints, sir. If there is history of vomiting, poor oral intake, if there is any history of fever, cough, breathing difficulty, diarrhea, weight loss, history of fever and skin rash. Since when did they notice the increase in head circumferences? If there is any history of irritability, lethargy, or decreased level of consciousness. In past medical or surgical history, I'll ask about if there is any history of recurrent respiratory tract infection, congenital heart disease, neurological abnormalities, bronchial asthma, muscular dystrophy. If there is any history of previous surgical procedure being done. Mm. Coming to antenatal history, I'll ask if there is any if it is a natural or artificial conception, if all the 3 trimesters were uneventful, if the mother had any history of diabetes, hypertension, thyroid disease, or infection, if there is any history of maternal drug intake or irradiation, if there is any history of smoking or alcohol consumption during her pregnancy. Birth history, if it is a preterm or a term delivery, if it is a vaginal or lower segment cesarean section, if there was any complication during delivery, and I'll ask about the weight of the baby, if the baby cried immediately after birth, if there is any history of asphyxia or cyanosis after birth, if there is any history of NSU admission. In family history, I'll ask about history of consanguineous marriage and any history of similar presentation in the family members. Coming to developmental history, I'll ask about the history of head control, if it is if the head control is achieved, and if the baby can sit without support, walk with support, if they have noticed any delayed milestones, and immunization history, if the child is immunized till date, if there was any adverse reaction to the immunization, nutrition history, if there was a history of exclusive breastfeeding, if there is history of current poor oral intake and failure to thrive. In personal history, I'll ask about the history of bowel and bladder habits, if there is any history of decreased urine output. In drug history, I'll ask about the allergy to drugs and if the baby is currently on any medications like diuretics or anti-seizure drugs. In general examination, I'll examine if the baby is active, alert, or lethargic, and I'll measure the anthropometric measure, height, weight, and head circumference of the child. I'll look for pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema, and if the child is febrile or afebrile, and in head to toe examination, uh, there might be enlarged scalp, which is shiny, and dilated scalp veins. I look for if there is any bulging or sunken fontanelle, if there is any associated facial anomaly like cleft lip, cleft palate, and if there is any upward gaze palsy, and I'll look for a McEwen sign, which is a crackpot sound on percussion of the scalp because of the dilated ventricles. And I look for evidence of dehydration if the baby has dry mouth, skin turgor, sunken eyes, and I look for any associated spine deformity. And vitals, I look for heart rate, NIBP, respiratory rate, and saturation. And in systemic examination, in CNS, I'll do cranial nerve examination and then motor examination if the tone is normal, if the reflexes are active, and if the baby is active or lethargic. In a respiratory system, I look for bilateral symmetrical chest movements if there is bilateral air entry is present, or if there is any added sounds. In cardiovascular system, I look for heart sounds, or I look for any palpable thrill or murmurs. In para-abdomen examination, I look if whether the abdomen is soft, if there is any tenderness is present, if there is any palpable mass, and the bowel sound is heard or not. And coming to airway examination, I look for adequate mouth opening, any facial asymmetry, and I look for any associated cleft lip or cleft palate if the tooth is loose. And coming to investigations, I'll ask for complete blood count and then serum electrolytes with renal function test. I'll ask for random blood sugar, blood grouping and typing, ECG echo to rule out any congenital heart disease, CT, MRI, and chest X-ray. Anesthetic concerns in this patient, it is a pediatric, the child is a pediatric age group, and because of the large head size, there might be a difficult airway, there might be difficult mask ventilation and intubation, difficulty in positioning, and hypothermia. Because of the poor oral intake, the child might be dehydrated, so difficult IV access, dyselectrolemia, hypoglycemia should be looked for. And then because the child might have delayed gastric emptying, so there might be a risk of aspiration. And concerning the surgery, there will be a risk of air embolism and neuronal injury. Goal in this patient is to prevent further rise in ICP, and to prevent hypercarbia, hypotension, and hypoxia, to prevent hypothermia, to maintain normovolemia, normothermia, normocapnia, and normotension. In pre-op preparation, I'll explain the anesthetic plan to the patient. I'll obtain informed consent, and I'll explain the NBO guidelines: 6 hours for solid, 4 hours for breast milk, and 2 hours for clear fluids. If the patient is on diuretics, I'll ask for serum electrolytes on the day of surgery, and I'll optimize hydration preoperatively. If the patient is on anti-seizure medication, I'll ask them to continue it on the day of surgery, and antibiotic to be started if the patient has infection and is febrile, and I'll avoid pre-medication on the day of surgery because it might mask the neurological status. So there will be hypoventilation. And intraoperatively, I'll set the OT temperature to 27 degrees Celsius. I'll make sure the anesthetic workstation and suction apparatus is checked, and I'll prepare appropriate airway equipments. Difficult airway cart will be kept standby, and the anesthetic drugs and emergency drugs to be loaded accordingly to appropriate weight of the child. After confirming the NPO status and informed consent, I'll take the child to the OT and place on the warming mattress. I'll cover the head to prevent hypothermia, and rolled sheets to be placed under the shoulder of the child, and the head is to be placed in a neutral position. We can place the head in the head ring to maintain stability of the head. And the monitors, I'll attach standard ASA monitoring, ECG, pulse oximeter, NIBP, precordial stethoscope, ETCO2 and temperature monitoring. If the patient is hemodynamically unstable, I'll go for invasive blood pressure monitoring. Induction, my plan of anesthesia would be general anesthesia with endotracheal tube under controlled ventilation. If the IV access is not available, I'll secure a line using sevoflurane induction. If the IV access is already present, I'll go for IV induction agent, thiopentone or propofol. Thiopentone of 3 to 5 mg per kg dose and propofol of 2 mg per kg dose. I'll avoid ketamine. Fentanyl 2 mg per kg to be given, and IV lignocaine 1 mg per kg to avoid laryngoscopic response. So once I check bag and mask ventilation is confirmed, I'll give a succinyl colon 1 to 1.5 mg per kg with adequate after 1 minute with maintaining adequate depth of anesthesia. I'll do gentle laryngoscope, and I'll intubate the patient with ET tube of 4 size and fixed at 12 centimeter. Once the intubation is done, I'll position of the patient during the surgery is supine with head tilt and slight head up. My IV fluid of choice would be NS or oral. Fluid warmers to be used to prevent hypothermia. I'll avoid dextrose containing fluid, and I'll maintain normocapnia, normothermia, and I'll avoid hypotension. Maintenance of anesthesia, I'll use sevoflurane less than 1 mg plus oxygen and air with a non-depolarizing muscle relaxant atracurium. During incision and subcutaneous tunneling, there might be response. So local infiltration can be done. And we can also deepen the plane of anesthesia. We can use low dose of fentanyl, and paracetamol can be given. During cannulation of ventricle, we have to watch out for fall in BP, as there will be a sudden decrease in ICP. And coming to extubation, if the extubation is depend on the patient's hemodynamic stability. If the patient is unstable preoperatively with poor GCS, I'll opt to electively ventilate the patient. If the patient is hemodynamically stable, smooth emergency is mandatory. We have to give antiemetic 0.1 mg per kg IV 60 minutes prior to extubation. I'll make sure the patient is adequately warmed, neuromuscular blockade is completely reversed, and the child is completely awake. Post-operatively, I'll maintain adequate analgesia using local anesthetics, local infiltration, and paracetamol or diclofenac suppository can be used. Paracetamol 50 mg per kg and diclofenac of 1 mg per kg. Low dose fentanyl can be used, and we have to maintain normovolemia, normothermia, normotension postoperatively. Close monitoring of vitals and urine output is mandatory, and frequent neurological examination is to be done. That's all.
Okay. Only miss probably in your flow of presentation, you said I will discuss with the patient about the anesthetic technique and the thing. You cannot discuss it with a 9 months old baby. You must do it with the parents or the caregivers, whoever is there.
Yes, sir.
Otherwise, you have gone through all the points correctly. The main important thing is we must see clinically whether there is a evidence of raised ICP in the form of child being very lethargic, having projectile vomiting, and altered sensorium or lack of sluggish reflexes. All these things indicate, despite the baby being only 9 months old, initially, how does the pressure gets accommodated here? If the child's head circumference is going on increasing, what is the mechanism of how the first of all, what is the definition of hydrocephalus? How do you define hydrocephalus?
Sir, hydrocephalus is abnormal accumulation of cerebrospinal fluid in the ventricles because of the increased production or decreased absorption, sir, which ultimately result in increased ICP.
Very good.
And initially, since it is a 9-month-old child, the sutures won't be fused and the fontanelles will be open, sir. So the child will be compensating with the enlargement of heads.
So in spite of this compensation, if the child becomes listless or lethargic, what does it indicate?
It indicates the compensation is
inadequate and patient is
inadequate,
in a very high
so
degree
the
of
child is developing
intracranial
the
pressure
signs and
rise.
symptoms.
Okay,
Yes,
that
sir.
is the meaning. So that is the such patients only have to be taken care of more intently rather than a patient who is active, alert, and otherwise normal just comes with an enlarged. What is the average head circumference in a newborn?
It is around 35 centimeters, sir.
34 to 35 centimeters. How much increase will happen as the child grows in a normal healthy baby?
Sir, in the first 3 months, the head circumference will rise by 2 centimeters, sir. From 3 months to 1 year, the head circumference will increase by 2 centimeters every 3 months. From 1 year to 3 years, the head circumference will increase by 1 centimeter every 6 months, sir.
Right. So that is the normal rate of increase, but in hydrocephalus, it may increase many-fold. It may become suddenly 45 even by the end of 3rd month or 4th month. Okay, so that is how you find out. What is sunset sign?
Sunset sign is upward gaze palsy, sir. Upward gaze palsy.
Upward gaze or downward gaze?
Upward gaze palsy, sir.
Palsy.
So there will be a down.
So the child has a downward gaze.
Downward gaze.
All the time
Yes,
the
sir.
eye is looking down. What are the
Yes,
other
sir.
features in that? Why you call it a sunset sign?
Sir, because the pupil will be covered by the lower eyelids, sir.
Very good.
And the sclera will be visible, so it will be like a sunset, sir.
Setting at the when you go to see the sunset in Kanyakumari or other seashores, that is the way. So the lower border of the pupil is covered by the lower eyelid, and there is a clear margin of sclera seen above the upper limbus of the cornea. So that gives what is called the sunset sign. Very good. So what are the etiologies of this particular condition? Is it always congenital or it can be acquired also?
It could be acquired also, sir. Congenital or acquired. It is communicating or non-communicating, sir. In both, we'll have both congenital and acquired, sir. In communicating, sir, it is choroid. We can the patient might have choroid plexus papilloma or carcinoma, sir, and post-infectious causes like TB, meningitis, sir. In non-communicating, it could be due to aqueductal stenosis, Dandy Walker malformation, Arnold Chiari syndrome, sir.
Okay. So is it the only classification or any other classification is there for the etiology?
Sir, age-wise also we can classify like pediatric, juvenile or adult, sir. And
Very
pathological classification, sir.
Yeah.
Because of the infection, sir.
Very good.
Functional is communicating and non-communicating.
Non-communicating. Very good. Okay, so there are 4 types of classification, whichever the examiner assess, you can say that. And what are all the surgical options for correcting this particular defect?
In emergency cases, we can do external ventricular drainage, sir. Electively, we can do ventricular peritoneal shunt or ventricular atrial shunt or ventricular pleural shunt. There is also thecoperitoneal shunt, sir. And there is also ventriculostomy. There's endoscopic ventriculostomy, third
ventriculostomy. Okay, not
yes,
just ventriculostomy, third ventriculostomy. Or sometimes they can do excision of chloride plexus also in cases where it is because of the excess production. Choroidectomy, choroidectomy is also done. So these are all the points that you have to remember. And with regard to airway, difficult airway management, you just mentioned about placing 2 folded towels under the shoulder and the upper body to make the head rest on the table and go ahead with the intubation. What are the other options you have?
Other options, we can bring the child to the end of the table, sir. We can ask assistant to hold the head, sir. Or we can do the intubation in lateral position, sir.
Okay. Any other newer gadgets which will be helpful to intubate?
We can use video laryngoscope
very good.
to intubate.
So that is also another option that you have to keep in mind. Okay. So very good. These are all the points that are commonly asked. So we'll just go for